Welcome to all of you, and thank you for attending. I'd like to particularly thank Dr. Tom Cole, Director of the McGovern Center for Health and Humanities, as well as Jeffrey Spike and Stephen Linder for their contributions to this symposium. I'm very, very sorry that I can't be with you today. I had certainly planned on attending, but at the last minute I was called away to a Board of Regents meeting, and as you probably know, you don't say no to the Board of Regents. So we're going to do this by video conference. I wanted to make a couple of comments about this heinous episode. The release of the report by Susan Reverby about the human subjects abuse in Guatemala affected me very viscerally, and I will say personally. You may know that I spent 16 years at the University of Pittsburgh, where John Cutler performed these experiments. And when I learned about these acts, I was really very, very strongly affected. And as a result of that, I thought it was very important that we hold an educational symposium to talk about how to make sure that we never engage in this kind of behavior ever again. There are acts of omission and acts of commission. John Cutler, unfortunately, engaged in both, but I want to say that this particular act of commission is particularly psychologically and philosophically disturbing. As terrible and upsetting as the Tuskegee experiment was, which Cutler was also peripherally involved in, wherein African American males were passively followed without treatment even after the time that it was known that penicillin could cure syphilis. I found this particular experiment even more shameful. Here, Cutler actively infected subjects with a known pathogen. I think this raises two very important questions. One is, how could it be that John Cutler could have done things that today we consider to be so black and white, so clearly wrong? But the second, and perhaps even more important, is how is it possible for any of us to slip down this same slippery slope? First, let's talk about John Cutler's behavior, and I think we have to view that in an appropriate historical context. These acts occurred in the 1940s and early 1950s. They happened before the Belmont report that so clearly formalized the ethical conduct towards human subjects. On the other hand, they happened during and after the Nuremberg trials, so there was clearly a discussion of research ethics going on, and it's ironic that similar behaviors towards human subjects were prosecuted amongst the Nazis and then employed amongst American public health leaders. Second historical context is that Cutler performed these studies in Guatemala. At that time, there was a great deal of institutionalized racism, that lives abroad were simply not the equivalent of lives here at home. One could even view the building of the Panama Canal, which happened at the turn of the 20th century, as a tale of the known putting at risk of thousands of lives amongst Caribbean workers and South American workers, and really the disrespect for those lives. Today, we certainly better understand the inappropriateness of thinking about individuals abroad as being different from individuals here at home, but there is continued controversy about the way in which we conduct clinical trials in foreign nations, which I'll come back to in a minute. The third aspect of this is that there was a long history of the use of prisoners, people in mental health facilities, and other captive populations in research. Today, we understand the need to take special precautions, even particularly great precautions, when we deal with captive populations such as this. And we understand that the view that Cutler took, which is that it's acceptable to put those populations at risk, is really wrong. And the final aspect is that Cutler clearly was working within a classic utilitarian philosophy. The utilitarian ideal is that it's acceptable to put a few lives at risk in order to, for the good of the whole. If you look at Cutler's correspondence at the time, it's very clear that he considered it to be acceptable to sacrifice a small number for the benefit of a much larger number. So it's really that last point which I want to use to segue to, I think, what's very important as a take-home for all of us today. So we can see that Cutler was really working in a very different historical context. It certainly isn't to say that what he did was right at all, but I think that now we understand much better, again, from our own historical perspective, that what he did was so clearly wrong. But that last point, that utilitarian point of view, is one that makes me still concerned today. It is so easy to slip down that slippery slope for all of us. Pure utilitarianism can allow us, as well-intentioned scientists with the best interest in public health, to think that perhaps it is acceptable to put a few at great risk for the good of the whole. Is it ever acceptable? Is the first thing we have to ask when we consider this utilitarian point of view is there an alternative? For Cutler's work, there clearly was. Observational data that involved infected individuals would have taken longer and would have been more difficult because they would have had to have been already infected. But clearly that was an alternative way of obtaining the same results. The potential there, in fact, was to benefit those infected individuals by giving them penicillin versus to harm those who were actually infected by Cutler. The second question that we have to ask, in addition to that first one about is there an alternative, is there a benefit to the subjects? Clearly, for Cutler's experiment, there was no benefit, but for the alternative that I just suggested, there clearly would have been a benefit. Third thing that we have to ask is, what is the standard of care? Controversy continues even today around some clinical trials that are done internationally in this regard. For instance, HIV-infected subjects in Africa might have no access to HIV drugs. Is it fair to randomize them to a control intervention that represents a standard of care that would be unacceptable in the United States? That's still a huge question mark, and many people say it's not acceptable, even if the standard of care is different. And then finally, and I think perhaps most importantly, it's important to take a patient-centric point of view when conducting research. And to take that patient-centric point of view is very easy. You simply ask yourself the question, would I be willing to be involved in this research? Would my child be involved? Would my parent be involved? If the answer to that question is no, I think you have to stop and think very, very long and hard about whether it's ethical to conduct such research. So what does all of this mean for scientists who truly want to make the world a better place for society? It's all about balance. Benefit to society is a part of the decision-making, but risk to the patient is the counterbalance. Sometimes risk to the patient is acceptable, in fact, unavoidable. For example, in new surgical procedures, in high-risk medications for patients who are dying. The potential for loss of confidentiality is the case in most epidemiologic and health services research studies, and it is an unavoidable risk that we take. So the balance of the benefit to society against the risk to the patient is what is really paramount. But the larger numbers of patients in society do not swamp this equation. Moreover, commission remains terribly concerning. The Hippocratic Oath says, first, do no harm. Purposeful harm is never something in which I believe we can engage.